Thank you. The next case is subclavian stump syndrome following thoracic endovascular aortic repair, presented by Dr. Jinwala.
Hi, my name is Felecia Jinwala, and I am a second-year vascular surgery fellow at the University of Maryland Medical Center. Today, I will be presenting on subclavian stump syndrome following thoracic endovascular aortic repair. I have no disclosures. As background, because of the need for an adequate proximal seal zone, nearly 26 to 40% of patients undergoing thoracic endovascular aortic repair require left subclavian artery coverage. The Society for Vascular Surgery guidelines currently recommend left subclavian artery revascularization during elective and urgent TEVAR. Common carotid artery to left subclavian bypass is the most common mode of revascularization in a Zone 2 TEVAR. A Zone 2 pathology refers to the segment of the distal margin of the orifice of the left common carotid artery to the distal margin of the left subclavian artery orifice. A carotid subclavian bypass allows for decreased risk of paraplegia, anterior circulation strokes, arm ischemia, and vertebrobasilar ischemia. This procedure is typically done through a supraclavicular incision through which the distal subclavian artery is exposed and a bypass is performed using a short 8 mm polyester graft. However, less well defined is the management of the native subclavian stump, and in fact, embolization may occur due to thrombus layering in the native subclavian artery. Here, in the image depicted, we see a left carotid to subclavian artery bypass, and if we imagine the area indicated here as thrombus, we can imagine this would embolize through a patent left vertebral artery. This would lead to vertebrobasilar insufficiency. Posterior circulation infarcts may result from this. Posterior circulation of the brain typically refers to region of the brainstem, cerebellum, thalamus, and occipital cortex. Posterior circulation TIAs and strokes represent nearly 20% of all TIAs and strokes. Symptoms associated with a deficit in the posterior circulation include alteration in consciousness, alterations in visual fields, as well as dysphagia, vertigo, or hearing loss. Vertebral artery insufficiency can result from occlusive disease that interrupts flow to the posterior circulation or from hemodynamic mechanisms resulting in hypoperfusion. In the case of subclavian stump syndrome, however, the cause is likely embolization of layering thrombus not part of the systemic circulation. Next, I will review two cases in which patients underwent TEVAR with subclavian revascularization whose course were postoperatively complicated with posterior strokes. In the first case, an 81-year-old woman underwent a TEVAR with a left carotid subclavian bypass for a penetrating aortic ulcer. In her case, an 8 mm Gore ring graft was used, and she underwent uneventful TEVAR repair. Postoperatively, she was maintained on aspirin 81 mg daily. She presented 4 years later with a left occipital lobe infarct. The decision was made to take the patient to the operating room to better characterize her lesion. We accessed the left radial artery, and a 5 French radial sheath was advanced. A glide wire was advanced into the aortic arch, followed by an angled glide catheter, through which multiple fluoroscopic images were obtained in various obliquities. In the first image here, we note a patent left carotid to subclavian artery bypass. Next, the vertebral artery itself on the left was imaged and noted to be free of disease throughout its cervical portion. In the final image, and by the area highlighted in red, we note here layering of thrombus in the native subclavian artery, proximal to the takeoff of the left vertebral artery. Once this was identified, an 014 BMW wire was advanced into the arch, and IVUS was performed, which again demonstrates layering thrombus, which was mobile, proximal to the left vertebral artery. In this image here, we note layering thrombus again in the native subclavian stump, proximal to the left vertebral artery. This patient had multiple options which were not limited to surgical ligation, vertebral artery transposition, or use of a self-expanding covered stent. In her case, we opted for anticoagulation as her symptoms were minimal and this was an initial event after her procedure. In our second case, a 74-year-old gentleman underwent TEVAR with subclavian revascularization for a 6 centimeter descending arch saccular aneurysm. His other history included atrial fibrillation already on anticoagulation and had a previous CABG in which the lima and LAD were bypassed. Of note, he also had a current history of smoking. He presented 5 years from his index procedure with dizziness, an acute onset of incoordination, and a posterior headache, and was found to have an acute left cerebellar stroke on MRI. His preoperative workup also included a CTA, in which he was found to have a patent carotid subclavian bypass, and as depicted by the yellow arrow, a floating thrombus at the left subclavian stump. This thrombus here was lying proximal to the takeoff of the left vertebral artery, which is also demonstrated on this CTA. It was deemed that the cerebellar infarct was likely due from this layering thrombus. However, given his high surgical risk, we opted for endovascular intervention. The left axillary artery was accessed in a retrograde fashion, through which a 6 French sheath was advanced uneventfully. The axillary artery was then clamped distal to the sheath to control for outflow. The bypass itself was occluded using a 9x20 Mustang balloon, as depicted here in the image by the black arrow. An 014 wire was used to cannulate the left vertebral artery, and 2 open cell stents were deployed to transpose the origin of the vertebral artery endovascularly, which is demonstrated here by outlining in red. Of note, the Silk Road device was used to maintain flow reversal, which was confirmed both visually and fluoroscopically, and is demonstrated by the yellow-orange arrows. Also noted in this image is patency of the patient's prior CABG. Labeled here is thrombus once again in the native subclavian artery. This has now been excluded by the deployment of the 2 stents, allowing for exclusion of the left vertebral artery. Prevention of subclavian artery stump syndrome is still not well defined, but some options include a branch thoracic endograft as demonstrated in the reconstructed image here, subclavian artery transposition, or even the use of plugs with non-thrombogenic surfaces. More research is needed to better characterize subclavian stump syndrome as a disease entity following TEVAR. Here we propose several treatment options for patients who develop posterior circulation strokes. Medical management with anticoagulation, open surgical or endovascular therapy, and hybrid approaches are all considerations. More specifically, anticoagulation, left subclavian artery ligation, vertebral artery transposition, or endovascular stent grafting of the left vertebral artery should be considered reasonable options for patients who have posterior circulation infarcts following TEVAR. More research and treatment algorithms are needed to better elucidate this disease entity. Thank you. Hi, my name is Felecia Jinwala.
Thank you, Dr. Jinwala. Unfortunately, we don't know where Dr. Jinwala is, but the question that I would have is, how are they managing the orifice if the the subclavian artery after revascularization, whether they're putting plugs, coils, open ligation. I'm not sure if Dr. Wu or anyone in the audience has any thoughts on this. I myself personally prefer to ligate it or pack that with coils along with a plug at times, just to prevent this. I think with that, I think we're concluding the session, and I think we're on to the next session, which is I believe it's the scientific session at 4 o'clock Mountain Time. So thank you everybody for joining and for the great questions, and I really enjoyed moderating this. I'm sure. I don't know if Dr. Wu has any comments.
Great session. Thanks for participating, everyone.
All right.
Thank you very much.
Thank you very much.